Hi friends, welcome to the Emergency Medicine channel. Myself Dr. Ashik Envy, doing post-graduation in Emergency Medicine. In this video, we are going to discuss about hypernatremia. Okay, starting our lecture with the definition of hypernatremia. So the hypernatremia is defined as a sodium concentration, serum sodium concentration more than 145 milliequivalents per liter in association with hyperosmolality. Hyperosmolality should be there. So the serum's osmolality will be more than 295 milliosmol per liter. Okay, this is the definition of hypernatremia. Okay, the two major causes for hypernatremia is either a decrease in total body water, okay, which will leads to a net increase in serum sodium. Okay, so the second cause is a net increase in serum sodium. These are the major baseline causes for hypernatremia. Okay, now let's see which all patients are at high risk for developing hypernatremia. So the risk factors for developing hypernatremia. First one is elderly group of patients. Okay, elderlies are highly prone for hypernatremia. And second group is decompensated patients with decompensated diabetes mellitus. Okay, infants and hospitalized patients. Hospitalized people are highly prone for developing hypernatremia. Okay, now move on to the classification of hypernatremia. Hypernatremia is divided into three categories based on the volume status. Okay, fluid volume status, it is three different types of hypernatremia. Okay, we have hypovolemic hypernatremia, hypervolemic hypernatremia, and isovolemic hypernatremia. Okay, in hypovolemic hypernatremia there is a decrease in total body water. Sodium also decreasing, but decrease in sodium is less than that of total body water. So there is a relative increase in sodium. It will lead to hypovolemic hypernatremia. Okay, in hypervolemic what happens is the total body water is increasing, the serum sodium also increasing, but the increase in serum sodium is much higher than that of total body water. Okay, in isovolemic hypernatremia there is a decrease, actually there is a decrease in total body water with a normal serum sodium. Okay, these are the mechanism of each category of hypernatremia. Okay, now let's see the examples for each category. Okay, for hypovolemic hypernatremia the examples are either due to osmotic diuresis, maybe either due to osmotic diuresis or loop diuresis. Okay, or it may be due to vomiting, GI loss, vomiting or diarrhea. Okay, or in burns or sweating. Okay, these are the common conditions associated with the hypovolemic hypernatremia. Now move on to the hypervolemic. In hypervolemic, conditions are caused by either due to Cushing syndrome, okay, or primary hyperaldosteronism. Okay, it is same, the mechanism is same for Cushing and aldosteronism, or due to salt water intake. Okay, salt water intake, or also maybe because of hemodialysis. Okay, hemodialysis. So these are the causes for hypervolemic. Now the isovolemic hypernatremia is seen in central diabetes insipidus, partial diabetes insipidus, or nephrogenic diabetes insipidus, or in hypodipsia also, hypodipsia. Okay, so these are the various causes for each category of hypernatremia. Okay, Now moving on to the clinical features. So the symptoms of hypernatremia include nausea, vomiting, lethargy, increased thirst, okay, and also maybe polyuria if the sodium is wasting through the renal mechanism, okay. And on examination the signs include the patient may have hypotension or tachycardia, sunken eyes. In these all findings are seen in hypovolemic states, okay. Sunken eyes, dry mucous membrane, altered mental status, and also one should be looked for the signs of Cushing syndrome, like moon facies, fat deposition in the upper back, okay, fat deposition, and thinning of skin, okay. And one thing should be keep in mind is severe hypernatremia yields a mortality of 75%. Okay, so that's all about the clinical features and signs of hypernatremia. Now moving on to how to diagnose hypernatremia, which all investigation you should do before diagnosing hypernatremia. Okay, so the investigations include, first one is serum electrolytes, serum osmolality. Okay, you can also check urine osmolality. Okay, in urine osmolality, the interpretation will be like urine osmolality is less than 300. The cause for hypernatremia may be central diabetes insipidus or can be nephrogenic diabetes insipidus. And if the urine osmolality is between 300 to 800, the cause may be partial diabetes insipidus or may be due to osmotic diuresis. Okay, and also if the urine osmolality is more than 800, it is hypertonic dehydration. The cause is hypertonic dehydration. Okay, this is how you should interpret the serum osmolality. And the other investigation you have to do in hypernatremia is a Bun to creatine ratio, blood urea nitrogen to creatine ratio. Okay, if it is more than 40, okay, it is indicative of hyperosmolar dehydration. Okay, is indicating hyperosmolar dehydration. Okay, so you have to do this much in investigations. Now moving on to the final part, that is treatment of hypernatremia. Okay, treatment of hypernatremia. So the first step in the treatment part, is the volume deficit should be treated. Okay, if the patient is presenting with either shock or hypotension, the volume deficit should be treated with 0.9% normal saline. Okay, that is the first step in the management of hypernatremia. Now go to the second step. The second step is nothing but treating the underlying illness. Okay, so treat any existing underlying cause. Okay, for example, if there is fever, you can give antipyretics. Okay, and for vomiting you can give antiemetics. Okay, for diabetes insipidus you can treat with desmopressin. Okay, that is the second step. Okay, now moving on to the third step. Correction of patient's free water deficit. Okay, so now how to correct the patient's free water deficit? Let's see. So the water deficit, free water deficit is equal to, the formula is like current body water into plasma or serum sodium divided by desired sodium minus 1. Okay, this is how we calculate the free water deficits. So the current body water is like assumed to be 50% of body weight in men. Okay, and 40% in women. Okay, this is how we calculate. Here also, for calculating the desired sodium, for acute cases we can go a correction up to 12 milliequivalents. Okay, for chronic cases here also we are taking it is lower rate correction done in hypernatremia. Also for chronic cases it is at a lower rate than acute. Okay, it is 6 milliequivalents in 24 hours per 24 hours. Here also 24 hours. Let's see what is the mechanism in hypernatremia. Suppose this is your normal cell. Okay, during hypernatremia, what happens is the fluid from intracellular compartment will shift to the extracellular compartment. So there will be a shrinking of cell. Okay, will be cell shrinking. But what if the hyponatremia persists? Okay, there is sustained hypernatremia. So there will be adaptive increase. Okay, there will be an adaptive increase in cell size. Okay, like this. Okay, this is called adaptive increase in cell size. Okay, so if we are correcting this, now it became a chronic hypernatremia. Okay, after 48 hours, if the hypernatremia persists more than 48 hours, okay, there will be adaptive mechanism begins to act. Okay, so if we are correcting this hypernatremia slowly, okay, slow correction, we can restore the normal cell volume. Okay, normal cell volume. But what happens in rapid correction? In rapid correction, the cell become swollen. Okay, so there will be swollen cell. So this mechanism explained by why we are treating the hypernatremia in chronic case at a slower rate. Okay, so again moving back to the equation. Okay, so this is the third step of correction of hypernatremia. Okay, The third step is finding free water deficit. It is we are using the formula current current body water into plasma sodium divided by desired sodium minus 1. Let's do one example. Okay, we have a 60 kg woman. So we have a 60 kg woman presented with symptoms of hypernatremia, and her serum sodium value found to be 168 milliequivalents per liter. Okay, so now how to correct it? So for that we have to find the free water deficit. Okay, so as this is a woman, we have to take 40% of body weight as the current body water. So 0.4 into 60, that is a 40% of the body water, and we have our serum sodium, that is 168 divided by our desired sodium. Okay, for this case I am correcting the sodium 12 milliequivalents in 24 hours. Okay, so the desired sodium will be 156. Okay, so the desired sodium is 156 minus 1. Okay, so it will be like 24 into 168 divided by 156 is 1.07 minus 1. Okay, so it will be, the answer will be 1.68 liters. Okay, so the correction in 24 hours is 1.68 liters. Okay, so the rate of infusion should be 1.68 liters divided by 24. So the rate of infusion will be like 0.07 liter per hour, or it is in other words it is equal to 70 ml per hour. Okay, so this is how we calculate the total body free water deficit and how to infuse or correct the free water deficit. And the fluid of choice for correcting free water deficit is D5, 5% dextrose in water. Okay, but this method of correction is used only in case of severe hypernatremia. Okay, used for severe hypernatremia. Okay, for mild or moderate hypernatremia, the correction is usually done with 0.45% saline. Okay, at a rate of 100 ml per hour. Okay, and the last resort of treatment, if the patient is presenting with severe symptoms of acute onset, and you can instead giving D5 water, you can go for hemodialysis. Okay, hemodialysis, that's the last resort of treatment in hypernatremia. Okay, that's all about the hypernatremia. Hope you enjoyed this video, and kindly do subscribe my channel if you are interested in emergency medicine related videos. Okay, thank you for watching.